to look at section 6. Section 6 talks about common medical disorders associated with pregnancy. You agree with me that there are so many of them that we can't exhaust all. Every condition, every medical condition that occurs in any normal human being could also occur during pregnancy. But for the purpose of our discussion and for the sake of time, we'll be talking about the ones that are very common in pregnancy. This session will describe the common medical disorders in pregnancy. You'll be looking at the physiological changes resulting from pregnancy, which may modify the cause of some of the disorders. Remember that for each of these medical conditions, they could be existing before the pregnancy sets in, but the pregnancy could exaggerate the condition, or sometimes the pregnancy could also predispose the person to develop these medical conditions. By the end of this session, I expect that you'll be able to outline the common medical conditions in pregnancy, describe the effects of the above medical conditions on the mother and the developing fetus, describe the management of the various medical conditions, and describe the treatment adjustments to be made in all the medications due to pregnancy. This is the reading list. Now I want to start with malaria in pregnancy. Now for each of the medical conditions we'll be discussing, remember that you've done all of them into details and medical surgical nursing. So we will not be talking about the pathophysiology and all that. Of importance to us in obstetrics is the effect it will have on the mother and the effect it will have on the baby, and just a brief background on the incidence of this condition. Malaria is very common in the sub-Saharan Africa region. It's estimated that about 4,000 cases of severe maternal anemia result from malaria. And it contributes to 7,500 to 200,000 infant deaths annually. And maternal anemia also contributes an estimated 10,000 maternal deaths per year. And pregnant women are also found to be 4 times more likely to suffer malaria than other adults. And the reason for the difference is uncertain. It's also been found to be very common in primates than in multiparous women. In Ghana, about 8.4 million cases of malaria are reported at OPD and every year, with about 30% of them forming the OPD or total OPD cases. We also have 27.3% of all admission cases being as a result of malaria, and 7.2% of all deaths also result from malaria. Now in pregnancy, about 17.6% of all women who come to the antenatal clinic or report to the hospital are as a result of malaria. And then we have 13.7% of admissions in pregnancy also being due to malaria. And malaria also accounts for 3.4% of maternal deaths. Also remember that a pregnant woman could be affected by malaria parasites, but then may not show signs of peripheral parasitemia. We want to look at the predisposing factors. So we are saying that primates have increased risk, adolescents have increased risk. If you have any immigrants who have traveled from other countries that are not malaria endemic areas, they also have a higher tendency to develop malaria in pregnancy. Women infected with HIV and AIDS have immunocompromised conditions and are also prone to developing higher forms of malaria. And sickle cell clients in pregnancy also have a higher tendency to develop malaria. Now, if we're discussing malaria, malaria have effects on pregnancy, and the pregnancy also have effects on malaria. So this one is effect of pregnancy on malaria. This tells you that because the person is pregnant, it is influencing her ability to develop the malaria or influencing the effect of the malaria on the person. So in pregnancy, we record a high protein requirement in pregnancy because now the woman is also keeping a baby who also needs to be fed in utero through the placenta. And then because of this, the baby is taking the nutrients, so the requirement must be increased. And because of that, if the maternal protein requirement is not increased, the proteins are withdrawn from the maternal blood, and this is affecting the woman's immune system. And because of that, she becomes more prone to higher forms of malaria. Pregnancy also leads to cortisol levels that are increased, And this may also contribute to decreased cell-mediated immunity. And as a result, the pregnant woman may experience both increased parasitemia and also clinical disease. And it's also very common in the third trimester than in the first trimester. And also in pregnancy, there are more frequent episodes and more severe forms of malaria. Now, effect of malaria on pregnancy. So if the woman suffers malaria, to the mother, she may experience anemia, she may have increased uterine activity, it could even lead to a spontaneous abortion, we could have a preterm labor, and then maternal ill health in general. Malaria does not only affect the woman, it also affects the baby. Now the woman can have hypoglycemia. Remember that any condition that affects the woman also affects the baby. If this woman is having hypoglycemia, it means that there will not be enough at the placental site, enough or adequate supply to the baby. So it means it will also affect the baby. This woman could also experience pulmonary edema, especially in the puerperium, and then what we call placental malaria, where the placenta itself is full of malaria parasites, and the placenta may go through pathological changes. The fetal effects. This baby could be born premature. We could also experience intrauterine growth retardation. We could have a fetal death, increased perinatal death. A stillbirth could also occur. And rarely we have what we call congenital malaria, where the babies at the time of birth has malaria. It means that they inherited the malaria through the mother's placenta while they were still in utero. Clinical manifestations, I think we are all aware or we know about clinical manifestations in malaria. They are very common. But then we were referring to what happens in pregnancy. So a pregnant woman could experience malaria, but it could be asymptomatic. She may not show any signs of malaria, but then she could still be harboring the malaria parasites. Sometimes they could also have chills and fever, headache and muscle aching, malaise, dry cough, abdominal pains, anorexia, or vomiting. During the puerperium, it could also be a cause of puerperal pyrexia. On physical examination, this woman may look pale and may feel very ill. She may also experience tachycardia. Sometimes you may have hepatomegaly and then splenomegaly. Investigations and diagnosis for malaria in pregnancy, it's just like we have for malaria in all cases. Now let's look at the management of malaria in pregnancy. Management of malaria in pregnancy differs from management of malaria in any other person. And then WHO found out that to address the burden of malaria in pregnancy, it is important to adopt what we call the three-pronged package intervention. Now, in the three-pronged package intervention, we're talking about the intermittent preventive treatment for pregnant women, which is called IPTP, and then the use of insecticide-treated nets, which is normally distributed free of charge to the women at the antenatal clinic. And they also have case management of malaria illnesses and anemia, so that if the woman develops the condition in pregnancy, aside all the prevention, then there is a need for us to manage the malaria, but then it is managed differently as compared to that of any other person. So now let's start with the intermittent preventive treatment, or the IPTP. And this talks about the using anti-malaria drugs given in treatment doses at predetermined intervals after quickening or 16 weeks to clear a presumed burden of parasites. Now in IPT, what we do is that every country chooses a drug of choice, and this drug is given to the pregnant woman in intermittent preventive treatment. And this treatment is based on the assumption that every pregnant woman living in a malaria endemic area is prone to developing malaria during pregnancy and also transmitting the malaria through the placenta onto the fetus. In Ghana, our drug of choice is sulfadoxine pyrimethamine, which we usually call the SP. Now, the SP has been researched and tested, and it's been found to be very effective. And it has given a single-dose anti-malaria with the best overall effectiveness for prevention of malaria in pregnancy. It's been found to be safe with no side effects. But then women who have G6PD defects are not allowed to use this medication because they may have some reactions. SP is also called Fancida, and in adults it is given in single adult dose of 3 tablets at regular scheduled ANC visits during the second and third trimesters. So this woman will start At 16 weeks, or when quickening occurs, she takes the first dose, and after every 4 weeks, she comes and take another dose. And a maximum dose of 5 doses is required. So for each visit, this woman takes the 3 tablets. She comes 4 weeks intervals to take another 3 tablets till she completes the 5 doses. Now remember that there are proposals to increase this to 7 doses, but for now, Ghana is implementing the 5 doses. We started from 3 doses, and now we have increased to 5 doses. And remember that if you are administering SP, you don't give it to the woman to go home and take it. It is done under directly observed therapy, or what we refer to as DOTS. So the woman comes to you and take the medication in your presence. Now in the case management, this woman is given drugs or medications. She's given some analgesics. She may be given antiemetics and hematinics. Now, in pregnancy, we can have a complicated pregnancy or uncomplicated pregnancy, malaria. So it is treated as such. And if it is uncomplicated malaria, then we give anti-malaria tablets, we give artesunate amodiaquine, and then we also give some IV fluids to flush the system. If it is a complicated malaria, then we may go on to IV administration of quinine. And it is given deep intramuscular, and then as vomiting stops or the condition improves, the quinine is changed. If the woman can swallow the artesunate amodiaquine, then she goes back to the artesunate amodiaquine. And then all other nursing cares for malaria is rendered to this pregnant woman. The major complications of malaria, we have hemolysis. The woman could also be jaundice. We could have cerebral malaria, which is a complicated malaria. We could have renal failure in advanced forms. So this is the end of our discussion on malaria in pregnancy. Like I said, we've done a lot of malaria at all levels. So at this level, we're just looking at obstetrics, and we are looking at how malaria is affecting the woman and how it's affecting the baby, and the reason why there is a need to have an intervention even before the malaria sets in. Now for our next topic, we are going to talk about anemia in pregnancy. Anemia is one of the common disorders affecting humans in the world, and it is just as a result of a reduction in the oxygen carrying capacity of the blood due to decrease in red blood cell production or reduction in hemoglobin content or the quality of the hemoglobin. WHO defines anemia as a hemoglobin which is less than 11 grams per deciliter. Now, anemia in pregnancy is associated with an increased risk of maternal and fetal morbidity and mortality. It accounts to 2 to 12% of maternal deaths. The incidence prior to pregnancy, it is estimated that 18% of women in industrialized countries are anemic. In developing countries, about 56% of women are anemic, even prior to pregnancy. And if you look at the physiology of pregnancy, so many changes occur. We may have hemodilution. So if this woman enters into pregnancy already anemic, then you can imagine the effect of anemia that you will experience on the mother and also on the developing fetus. During pregnancy in Ghana, about 22% of all pregnancies are complicated with anemia. This is the general figure. In some regions, we have malaria being complicating about over 50% of pregnancies. Types of anemia. We have iron deficiency anemia, folate deficiency anemia, and then we have the hemoglobinopathies. Now, iron deficiency anemia has been found to be the commonest type of anemia in pregnancy, and about 90% of all anemias in pregnancy are as a result of iron deficiency. Remember that the developing fetus will depend on the mother for its iron supplies, and even if the mother doesn't take enough, the baby still takes adequate supply of iron from the maternal blood stores. So it depletes the mother of iron. And the second most common type is the folate deficiency anemia. Let's look at the physiological changes in pregnancy. In healthy pregnancy and prepuberty, they are associated with mild physiological changes in the circulating blood, and this increases the plasma volume, but the number of cells in the blood will not increase, and it leads to the condition that we call hemodilution, which means that there is increase in the plasma volume as against the cells. And there could also be alterations in the factors involved in hemostasis. And these changes have relevance to the most potential and hazardous hematological problems of pregnancy and delivery. In pregnancy, the plasma volume will increase by 50%, but the cells will increase by only 25%, as stated earlier on. So this means that the fluid part of the blood will be more than the cells, and this leads to hemodilution. And the fall in HB results in the second trimester, and it rises again gradually during the third trimester. And this we call physiological anemia. And if it is not complicated, and at the time that the woman was getting pregnant, she had a normal level of HB, then it's just physiological anemia, and it is compatible with life. Now we have said that the iron deficiency is normally due to the fetal demand, that the dietary iron for the woman increases from 2 to 2.5% in the 2.5 milligrams in the first trimester. And now it goes on as high as 5 milligrams per day in the second and the third trimesters. So if this woman is not replenishing her stores by taking in enough iron, then the anemia will occur. We have inadequate intake. Sometimes they have gastric disturbances, like in case of hyperemesis or diarrhea, and in the course of the excessive vomiting, they lose all the iron. And also in diarrhea, they pass a lot of fluid stools, and then some iron is wasted. Then some also have malabsorption syndrome. So women with malabsorption syndrome can take in adequate iron, but then it will not be absorbed. Some also due to social and religious and cultural preferences. Something she was taking when she wasn't pregnant, now she gets pregnant and religion is telling her not to take it, or culturally it is contraindicated. For instance, in some cultures, you find the women saying that you don't take eggs when you are pregnant, you don't take snails, and most of these cultural dietary inhibitions are related to either protein or iron, and because of that, this woman may not be able to take in adequate protein and iron. Excess blood loss when there is hemorrhoids or abortions, intrapartum hemorrhage, this woman could become anemic. Chronic infections like urinary tract infections, abnormal demand in multiple pregnancies and multiparity, this person will also demand more iron. And then malaria, as a result of hemolysis, the person becomes anemic. Has a sickle cell disease, then she has hemoglobinopathies and she could become anemic. Some have parasitic infections. It could be worm infestations. And for instance, if the woman has hookworm during pregnancy, it will feed on the woman's blood and deplete all the iron stores. In cases of HIV and AIDS, when they are immunocompromised, their iron stores are also affected and their proteins are also affected. Now let's look at the presentation of anemia. This woman becomes breathless on exertion, so the slightest energy she puts into anything, she starts panting. And then she sometimes, even when she is resting, she still has breathlessness. She has reduced exercise tolerance. There could be pallor, nausea and vomiting, lassitude, and then she could also have glossitis and gingivitis. Anemia in pregnancy, we have said that it is associated with an increased risk of maternal and fetal morbidity and mortality. For the fetal consequences, this fetus could have intrauterine growth retardation. Fetus is not getting enough nutrition from maternal stores. It's not getting enough iron. So growth in utero is retarded. So she can be born with a low birth weight. The fetus can come with some malformations and then perinatal mortality. Maternal effects. This woman could have fatigue, stress, decrease in work capacity. It could also lead to antepartum hemorrhage, and then she could experience abortions, and after bleeding, she could have postpartum hemorrhage. Remember that we're talking about the consistency of the blood being affected. So if the blood becomes very light at the time of delivery, then the woman can bleed more because the clotting factors are not there. It is just fluid. So the woman can really bleed, and the clotting factors will not be there to arrest the hemorrhage. Iron deficiency anemia. HB concentration decrease, and then these are all the lab investigations you can carry out on the woman. Red blood cells and HB are very important, and then the cells are found to be microcytic and hypochromic, and these tests give a basic guide to diagnosis and pregnancy. Remember that we have said that in malaria, in anemia, the woman's blood has become very light. And as you take the blood and analyze the blood, you'll be able to look at the amount which is fluid, or the volume of the fluid of the blood, and then you could also count the number of cells you have in that blood. Oral maternal iron prophylaxis is recognized to be associated with an increase in MCV. Iron absorption during the first trimester of pregnancy is decreased compared with the non-pregnant state, and non-compliance of mothers occur in less than 10% of cases. You confirm diagnosis in your management, so we don't just look at the peripheral parasitemia, we have to also look at the clinical manifestations, because you may take the woman's sample and it may be negative, but she could be still having it. So confirm diagnosis, and then you do a history and examination, you do some investigations. The treatment depends on the degree of anemia. Is it mild? Is it moderate? Is it very severe? If it is very mild, then just going on a good diet rich in vitamins and vitamin C and iron supplements will be very good for the woman. And then you monitor the hemoglobin levels. Now, early identification and management of the woman at risk is important. That is why when you go for routine antenatal visits, the woman's HB is estimated, and then interventions are made before she gets into severe anemia. And the woman should build the iron reserve after one delivery before embarking on another pregnancy. Like in the condition we refer to as pregnancy too soon, where the woman gives birth and then the next 3 months she's already pregnant. She's not been able to restore the iron deficit she had with the previous pregnancy. So when she carries on a new baby and the baby is also taking its iron from the mother's blood, then very soon the mother becomes anemic. Good nutrition is very important. Iron therapy, various forms, depend on the compliance of the woman. So if you go to antenatal, they have different forms of iron that they give to the woman. And then if you realize that this woman may not be able to take 3 times daily, then you can find a higher or a stronger iron that she could take just once a day. And some are also associated with GIT symptoms. And then you also look at the availability of the medication. If the woman cannot afford, then you prescribe what she can afford, and you look at the cost involved. We have the ferrous fumarate, ferrous sulfate, and the dose depends on the level of HB. And then supplement folic acid, and you have to give proper instruction to this woman, and you tell her what to expect, the change in the color of the stools. Some may have diarrhea, some may have constipation, and you should inform them before they start the medication, so they don't become alarmed. Sometimes you don't give them any information. Once they start and they see the black stools, they will stop taking the medication, and they may not come to tell you that. Or sometimes they get worried over signs that are just the drug related and are not really any life-threatening condition. In very severe forms, you can have the injectable parenteral iron, intramuscular or intravenous. It's only given in very, very severe forms of anemia. If the iron deficiency occurs in late pregnancy, then parenteral iron is required, because that will raise the HB faster than the oral iron. We want this woman to replenish her iron stores and build very high HB before she enters into labor. If not, she bleeds into labor and loses more iron, and then she becomes very anemic. In our management, you want to replenish the iron stores, you want to treat depending on the degree, and then we do various forms of lab investigations. We talk about iron nutrition and all type of therapies to replace. So we treat all parasitic infections apart from maybe malaria that could be causing the anemia. You should also rule out any worm infestations like hookworm infestation and any other form of parasitic infections that could lead to anemia. And then you treat according to the cause. Once you screen the woman and you see the cause, the treatment is not just on replacing the iron. If you replace the iron stores and the hookworm infestation is there, it will still be taking the iron. So the treatment is important that you find out what is causing the anemia, and then you treat accordingly. In severe cases, there may be the need for blood transfusion. And in this case, because we are having hemodilution already, we may have to transfuse maybe only the packed cells. For the mother, anemia could lead to abortion, it could lead to acute hemorrhage, it could lead to cardiac failure, it could also lead to puerperal infection. Because once you have anemia, your immunity is low. You lose more blood during delivery, and then during the puerperium, because of low immunity, you could have infection. To the fetus, she may have premature delivery. She may be born with a very low Apgar score. This baby can be in fetal distress, intrauterine growth retardation, and perinatal death as a result of anemia. In conclusion, malaria and anemia in pregnancy can be very distressing to both the mother and the fetus. Hence, prevention of anemia is crucial. However, if prevention fails, immediate intervention is needed to save the lives of both the mother and the fetus. There is a need thus for intensive education of mothers during antenatal clinic to foster the development of lifestyles that enhance the life of the mother and the fetus. These are the references.